Preoperative positioning and socket anchor technique for arthroscopic medial patellofemoral ligament reconstruction using allograft tendon. Conflict of interest. The video is part of the submission and has been viewed by all authors. The authors have no conflicts of interest to declare. 2 steel balls are fixed on the skin of the patient's knee joint by tape, one near the adductor tubercle and one on the medial edge of the patella. Undergo 3-dimensional computed tomography examination. Measure the positional relationship between the 2 steel balls and their connecting line and the femoral insertion point and patella insertion point of the MPFL on the picture archiving and communication system imaging system. Then, the predetermined MPFL point is marked on the patient's skin based on the measurement data. Make a 1 cm incision in the upper third of the medial edge of the patella. Soft tissue dissection is then taken down to the bone, which is exposed subperiosteally. A 2.3 mm Kirschner wire guide pin is drilled into the patella by approximately 25 mm parallel to the patella surface. A 10 mm deep bone tunnel is prepared by use of a 5 mm cannulated drill system, and a 3 mm bioabsorbable suture anchor is inserted into the end of the socket after a blind tunnel is drilled. Pull the end of the suture to confirm that the anchor is well fixed. The knee is flexed. Drill guide pin according to predetermined point. Create anteromedial portal. A large clamp is used to create subcutaneous tunnel from the anteromedial portal and patella portals to femoral portal. Using a shaver, we clean out the soft tissue around the guide pin. Then we use radiofrequency to condense the tissue and locate the adductor magnus tendon at the MPFL femoral insertion. Next, we confirm the adductor tubercle as the femoral insertion using the arthroscope at the femoral portal, adjusting the guide pin if necessary. The guide pin is then overdrilled using a 5 mm cannulated reamer to create a bone tunnel penetrating the femur. Tighten the suture tape on the anchor to the guide pin. The flexion and extension of the knee joint to test the isometric properties of the MPFL femoral insertion point. One end of the 2 strands of suture in the anchor is sutured to the midpoint of the graft to tie it tightly, with the other end of the suture acting as a guide wire. The graft is pulled into the socket and then knotted to the bone surface. The traction suture is pulled out by a clamp from the patella incision portal via subcutaneous channel, and the other ends of the graft are led into the femoral tunnel by pulling the traction suture. The knee is placed in 30 degrees of flexion. Manual tension is applied on the graft to restore the alignment relationship between the patella and the trochlear groove while adjust the MPFL tension by pulling the traction suture. With the guidance of a 1.5 mm guide pin inserting to the femoral tunnel, a 5 mm bioabsorbable interference screw is inserted to secure the graft. The radiofrequency is applied for lateral patella retinaculum release under arthroscopy. Tension was calculated on the basis that the patella could still be manually lateralized about 10 mm to avoid overconstraint.